Dear colleagues, dear Professor Nair, thank you, Professor Geleve Vasile, for invitation for participating in this beautiful meeting in Sofia. Our lecture about spontaneous coronary artery disease. 4% of patients with acute coronary syndrome have spontaneous coronary disease. Incidence of this patient is around 22% women with less than 60 years old. What is different in SCAD? In SCAD, almost all patient is women, and almost all patient is between 40 and 50 years old. What is different in the risk factor for SCAD? Only hypertension and smoking is same factor like traditional risk factor. Different is one part of patient have history, personal or family history of fibromuscular dysplasia. The biggest part of this patient is female, and this disease is related to pregnancy and hormone therapy, especially with contraceptive pill. We divide SCAD in 3 types. First type is dissection with intimal tear. Intimal tear made communication between true lumen and false lumen. Type 2 and type 3 is different. We don't have communication between true and false lumen. False lumen growing up by hematoma and blocking perfusion over the artery. If he is in the biggest part of artery, this is type 3. If he is in the short part of artery and probably more than 50% obstructed artery, this is type 3. Our patient is a young woman with typical chest pain, acute coronary syndrome, positive troponin. On ECG, we have changings. On echo, hypokinesia, parts of inferior wall. Left coronary artery is okay. Problem is right coronary artery. In right coronary artery, middle part, we have subocclusive lesion. And this patient from 10 years ago. Now we have exactly a recommendation how we treat and diagnostic patient with SCAD. Now we know that patient with TIMI 0 flow or significant reduced flow, TIMI 1, with chest pain, or patient with high risk of anatomy, or patient with persistent angina and ischemia must go in the PCI or CABG. All other patients can be treated conservatively. Why? Because until today, we don't have any randomized trial about this patient. All the data we have from the register, the biggest registry, Canadian SCAD register, and the biggest part of this patient, 85% treated conservatively, and after 1 month of treatment, almost then 95% patients have completely resolving problem on artery, spontaneous resolving problem. In our patient, we put the stent in medial and the distal part of artery. After that, you can see propagation of hematoma and dissection in upper than first stent. Next stent in this proximal part. After next stent, dissection grow up in the ostium of right coronary artery. New stent in the ostium coronary artery, and final result is good. We blocked with this stent propagation hematoma to aorta. This is very important. How we now treat patient with SCAD? If patient have SCAD and percutaneous coronary intervention, must have dual antiplatelet therapy. From dual antiplatelet therapy, only clopidogrel, not prasugrel, ticagrelor, only clopidogrel with acylsalicylic acid. 1 year, after that, continue with aspirin a long life. Statin only for patient with hyperlipoproteinemia or diabetes. This is not atherosclerotic disease. It is not necessary for all patients to get statins. Beta blockers for all patients if can't tolerate this drug. ACE inhibitors for all patients with arterial hypertension. Nitroglycerin only for patients with symptoms. When we made the mistake in our patient in this case, now we know we have 3 strategies for resolving this patient with SCAD in cath lab. First strategies is put single stent technique. This technique is very good for short lesion, for short tip 3, very common. In this patient, we put stent over the hematoma, but this stent must be longer 1 centimeter proximal and 1 centimeter distal from the hematoma. Multi-stent sandwich technique is stent with this technique with 3 or more stents, short stents. First stent we put in the proximal part of artery in proximal part of hematoma. Second stent we put in distal part of hematoma. This way we blocked and isolate hematoma in this segment, and third stent is between first and second. Third options is patient we can treat it with cutting balloon. We choose cutting balloon no more than 2 millimeter size and inflating no more than 2 or maximum 4 atmospheres. After that, we can continue treated patient with medication on put stent in this patient. If you use stent, actual recommendation is to use drug-eluting stent, but maybe in the future time is good solution for this patient, BVS stents. Second patient, 33 young woman with chest pain, acute myocardial infarction, on echocardiography, hypokinesia of apex and distal part of lateral wall. What is special for this patient? This is sister from first patient. On angiography, right coronary artery is okay, circumflex left main is okay. Problem is in the medial and the distal part of LAD. We know for history of his history and spontaneous coronary artery dissections, and in this moment we stopped with intervention and continue with drug treatments. What is conservative treatment for patients without stent, without PCI procedure in SCAD? Same is like a patient with PCI, only different is duration of dual antiplatelet therapy. In this way is 1 month, and after that continue only with aspirin. After 3 months, we can repeat coronary angiography for this patient in Belgrade. You can see normal finding in right and left main circ artery, and completely normal finding in the LAD. You can compare this finding before and after SCAD. SCAD is a typical form of coronary artery disease. Main substrate is intramural hematoma. This is not atherosclerotic disease. When you work in cath lab, you must have on mind SCAD patient model, potential SCAD patient model. This is young woman, young patient in all, very common young woman without traditional risk factor for coronary artery disease. If a patient have TIMI-0 or TIMI-1 flow with chest pain, you must do PCI procedure. If patients have any better TIMI flow, you can stop and continue with conservative treatment. Over the 95% of patients after conservative treatment have spontaneous resolution on artery with SCAD. Last slide is our registry for SCAD patient in Serbia. PI of this registry, Professor Svetlana Apostolovic. In this moment, we have more than 70 patients in the registry. I invite you to participate in the registry. In this way, we can grow up this registry like regional or Balkan registry. Thank you for your attention.
Thank you for that presentation. Any comments or questions from panel, audience?
Sashko?
We have a lot of patients probably with the SCAT, as I saw in Serbia, probably in Bulgaria too. About statin therapy with SCAT, because as we said, those are not patients with hyperlipidemia, but we forget the anti-inflammatory effect that have the statins of the vessel. That's why in our practice in Macedonia, we regularly give statins to this kind of patient, dislike of the hyperlipidemia, because of the anti-inflammatory effect that statins give to this intramural hematoma. This is the only thing that actually we do different from.
We didn't know that is problem inflammatory like in the atherosclerotic disease. We know that that is not atherosclerotic disease, and only patients with comorbidities like diabetes and high lipoproteinemia have a strongly recommendation. In real life, the biggest part of patients have statin in therapy.
I have some comments about treatment. When you recognize SCAD, if you recognize SCAD in your first injection, please defer from doing more injections, because hard injections can sometimes propagate the dissection through hydrostatic pressure. Second is if a patient is having an MI, you stabilize the patient as much as possible so that you avoid putting wires, imaging, catheters, stents in these vessels. So, because as you know, these patients, as you showed, heal very well. So if you can avoid stenting, avoid it. Of course, when you're having an acute MI and the patient is in shock, then you can use some of the stenting technique. Surgery is an option, but please find a surgeon who will operate, and you will not find too many who will operate on patients that is having spontaneous dissection, because when you start sewing grafts to these single vessels, they don't do very well. The cutting balloon is a good technique, very gentle cutting, because those blades will cut the intima and relieve the hematoma, and your obstruction will be resolved, and you can get away without stenting. Finally, in terms of clinical scenario, I have one question, and I don't know what the experience of most people are, is that this is very often associated with pregnancy. So the dissection can occur during the third trimester, during labor and delivery, and even a few weeks to months afterwards. So what do you advise this patient of yours? Usually they want to have more children. Should you or should you not get pregnant again? It's a very ethical question. I don't have an answer. Second is that it's worthwhile investigating these patients for other areas of fibromuscular dysplasia. So ultrasound, Doppler examination of the carotids, renal arteries, etc., to see if there is other vascular disease, because this patient may present the next time with a stroke from carotid artery dissection. That's important. And second is to screen other family members for fibromuscular dysplastic lesions, because they may also have the same thing. So some comments and a question, and I don't know if anybody has a question about or an answer to this question: should I get pregnant again?
I'm not sure, but I think this is not problem next pregnancy for this patient. We don't have any proofs to his risk for a new spontaneous coronary artery dissection.
I think if you don't have fibromuscular dysplasia, if you don't have a family history, and the lady really wants to get pregnant, you have to tell them it is possible. We just don't know.
Yeah. Fibromuscular dysplasia is the biggest problem.
Yes.
This is diffuse disease.
Yeah, it's working.
It's working. I have just a technical recommendation to do. Those who do CTOs, do you know the wire SUO03? It's an exceptional tool if you have a dissection and you can't cross with some normal workhorse wire. The SUO03 is a really soft that goes through the dissections pretty well. So that's just a technical recommendation, and we use it, let's say, if we want to do something, almost 100%.
Data from the registry, more than third part of patient have stent in false lumen in SCAD.
Unfortunately, deferral of further pregnancy is very, very hard advice and decision, and we don't have data. And probably the most fair answer of this, if somebody asks, is just to tell we don't know. Sometimes it happens that we have to say that.
Yeah.
And this is, and to be honest with the patients, because there is also afterwards, there is a legal responsibility afterwards. Okay, did the colleagues from Veliko Trnovo are here for the first case? Okay.
Working? Hello. Hi, my name is Dr. Maria Tsvetkova. I'm from Cardiology Hospital Veliko Trnovo. I am here to present for you the best outcome despite hardships. So our case begins with a 76-year-old female patient that was admitted in our hospital with precordial oppression, shortness of breath and fatigue. Her symptoms have started a couple of hours before her admission. So upon arrival, her blood pressure was 70 to 50 millimeters of mercury and her heart rate was about 40 beats per minute. She was also orthopnoic and had cardiac asthma. Most notable from her medical history is the fact that she has arterial hypertension and also type 2 diabetes. When she came, we of course took some blood samples to do the necessary blood work, and the most notable of them is that there are quite elevated cardiac enzymes. As you can see, the high sensitive troponin is above upper limit. The next thing we did was an ECG. An ECG showed sinus rhythm with the ST elevation of about 1 to 2 millimeters in leads, second, third, AVF, V4 to V6, also a QS in the second, third, and AVF leads. Next, we moved to echocardiography that showed left ventricular hypertrophy, also hypokinesia of the posteroseptal, posterior, and posterolateral wall of the left ventricle in the basal and middle segments at ejection fraction of about 40%. Both atriums had normal sizes and there were no notable lesions on the heart valves and no pulmonary hypertension. After that, we moved the patient into the catheterization lab and we did a coronary angiography. The results from that were right type of circulation, left main with no stenosis, LAD with stenosis that were below 30%, D1 that had 70% stenosis in the middle segment, also a circumflex artery that was actually the infarct-related artery. She had acute osteoocclusion with TIMI0 flow and right coronary artery that had stenosis below 30%. With all the gathered information, we concluded that the diagnosis of the patient was STEMI of the posterolateral wall of the left ventricle that was caused by the acute osteoocclusion of the circumflex artery that we further treated by implanting drug-eluting stent in left main to circumflex. So about the procedure, as always, we start by gaining arterial access through the right radial artery of this particular patient. We put wires in, also a catheter. We reach the heart, visualize the coronary vessels. Of course, this is part of the coronary angiography. Then we started the procedures. We wired LAD and the circumflex artery and with predilatation of we did a predilatation of the circumflex artery. Blood flow appeared, but there was still a big residual thrombi in the vessel, and that was in the proximal part. That's not here, sorry. I'll return, no. I don't know, somewhere went, okay. So we did the pre-dilatation, visualized the thrombus, we did another dilatation and also administered the bolus dose of tirofiban. The visual flow was good, so we decided that it was time to implant the drug-eluting stent. The first stent that we started to implanting, actually, while it was in the brachial artery, it unraveled, so we had to take it out. The next was successfully implanted in left main to the circumflex artery. So after the successful implantation of the drug-eluting stent, we noticed that there was still some residual thrombi in the left circumflex artery, so we did another bolus dose of tirofiban. After that, the visual result was pretty good, so we decided that it was time to end the procedure and started taking out the wires that were in LAD and the circumflex artery. While taking out the one that was in LAD, a part of the guide wire ruptured and remained in the vessel. So, yes, thank you. So we decided that we were going further with the procedure regarding the infarct, and we decided that it was time to do a kissing dilatation. So the kissing dilatation actually optimized the result regarding the circumflex artery, but what it also did was push the piece that was ruptured further away in the LAD, and also push the strati of the stent further away so that we can make a bigger lumen to catch the ruptured piece with a big snake catheter. At the end, the result was good, so we decided to end the procedure, but we did one final checkup of the coronary vessels, and we noticed that the atrial branch of the circumflex artery that was visual in the in the beginning of the procedure was nowhere to be seen, so we added another diagnosis to the whole bunch of diagnoses that the patient has, and it was atrial infarction. So in the first 48 hours after the procedure, the patient was electrically unstable with a lot of tachycardia and bradycardia episodes. So the tachycardia episodes had white complexes, so we accepted those as ventricular tachycardia, and the bradycardia episodes looked like nodal rhythm. The tachycardia episodes, unfortunately, were hemodynamically significant, so we had to use cardioversion and also administer some antiarrhythmic medication. Those measures turned out to be ineffective, so we had to put temporary pacemaker in VVI mode. Sorry. Yes. In the following days, the patient's electrical activity stabilized and we were able to take out the pacemaker. Also, we did control echocardiography, which again proved the atrial infarction by the absent atrial contraction. Also, there was a newly found mitral regurgitation of second grade. The patient was then discharged on the 16th date without any ischemic signs or any signs of congestion, and she was in sinus rhythm. So in conclusion, I would say that despite the widespread use and extensive experience in performing PCI, some unanticipated complications can always occur, such as defective devices, anatomical abnormalities, or iatrogenic complications. There is still a lack of official statistics of the frequency of such complications and also clear recommendations for dealing with them. However, doctors must be fully prepared to meet them coolly and without panic, because usually we are talking about an emergency situation that threatens the life of the patient. So we had to have correct actions, and sorry. We need to have correct actions so that we can preserve the life and health of the patient. With the presented case, we wanted to show once again that there might be more than one surprise during a procedure, but with systematic approach, a lot of experience and correct actions, everything can end with a most favorable way for the patient. Thank you.
Just several advices.
Okay.
The first one, in those cases, it is much more preferable to have movies not still pictures. And the second one is just try to keep the text as less as possible. Just no more than 3 sentences
Considering the last slide.
per slide. Just it would be much more useful for the audience.
Thank you.
Ивзи, дайте, моля ви, микрофона горния. Сашко, може ли? Ето.
During the intercession, I was discussing with a colleague about that, about the facts, how to size a balloon, how to size a stent to treat a lesion. But in this lesion, this is an exception. Because in the context of MI, you have frequently vasoconstriction. So, in fact, if you choose the diameter you see, because the vessel was open by the predilation, will probably be too small to prevent acquired malapposition. So another aspect is to what we did was a very long time ago. We began activity in our group in primary PCI in 95. So I imagine it was around 2000. Providing we were absolutely sure that the wire was distally, we tried to do direct stenting for left main and to do direct and unique inflation. And of course, we have observed after that some malapposition. So another solution was to remove the thrombus before stenting. We have done that. We have participated to trials. And personally, Thierry Lefebvre, my brother also, we are convinced that in some situations, it's still very useful to thromboaspirate. So, and what is something we see, and which is a real problem, is that when you inflate your stent, you deflate the balloon, okay, you are happy, the flow is there. The flow is there. But you see, my stent is not deployed enough. So you inflate a second time, you deflate, and we call that the mechanism press purée. You know purée, huh? Press purée. So you cut in particles the thrombus, everything is going down, and the vessel has no flow. This is something we frequently observe. So today, that's why today I think that when you have presumed large amount of thrombus, it's better to remove.
Yes, go ahead.
Just 2 comments because what Yves said is extremely important. The first one is that I think that the guidelines too fast downgraded the thrombus aspiration, too fast and too aggressively removed the recommendation for the thrombus aspiration. Thrombus aspiration, probably routine thrombus aspiration, which means in every acute MI on STMI that should be done. It is not so wise, but to put the recommendations in like at the moment in highly selected patient, I think it's also not very wise. And the second point is that, and I just advise my fellows to do that when they implanted the stent during the STMI, just keep the balloon inflated at least 20-30 seconds, not like, and what this is even more important than every other situation. In STMI, you should keep the balloon inflated just to achieve the maximum stent position, because every second inflation and post-dilation, this is a road to no reflow and to bad result and to damaging much more myocardium. With every second, third post-dilation, it's a road to disaster, usually.
Dovrin, I perfectly agree with you. That's really not good that they downgraded the exploitation. But I think that we always do, if we have a large thrombus burden, especially in tortuous vessel, for example, in the parts that the thrombus, you cannot get to the thrombus. It's similar to rota, that you can rota blade just in one direction and not going to the other. So it's always good to do combined rota, combined export and dilatation to remove maybe the thrombus a little bit, and when the thrombus goes to a position that you can take it out, you take it out. And usually also with these large thrombotic burdens that you have a thrombus after a curve, you know, we try to move the thrombus to a position that export can come there, because export is not that large as the vessel, so the thrombus can be removed. So we try, whenever we do thrombectomy, to take out as much as it's possible and not to have the, and this you can do it with ballooning and extracting, you know, in let's say balloon, extract, balloon, extract, balloon, extract.
I remember now another protocol was generated by one of our fellow, was to treat the MI in 2 times. So you come with a balloon, you open, you have a flow, you put patient in an intensive care unit, 3 days later you come back and you put the stent. And it has been tested. The result, you know, is difficult to say that it was always, in some situation, it was certainly a good option. I mean, when you have a major vessel with a very big thrombus, it's very likely that you will push everything at the distal part. And in this kind of big vessel, especially the right, sometimes you have 6 centimeters of a huge thrombus. I did sometimes not too close to the ostium, but in the middle of the second segment of the right, I push my guiding, aspirate with the guiding.
Now we have an issue about the trapped wire, and correct? The wire was trapped and broke in the LAD?
Yes, yes.
So this is a very unusual occurrence, and I don't know how it happened, because you have to pull quite a lot for this wire to break. So I don't, nothing against the operator, but I don't know how that happens. But it can happen, and there are a few caveats, a couple of caveats that I would like to mention. We leave wires behind stents all the time. The question always has been, should we use a hydrophilic wire or a non-hydrophilic wire behind the stent strut? Because the polymer jacketed wire may be a little more slippery. You can pull it out. However, the polymer jacketed wire can lose its polymer if trapped behind the stent. So personally, I use non-jacketed wire. Some of my colleagues use a jacketed wire. Of course, any wire can get trapped, but the way to test whether the wire is getting trapped or no is that you tug. Don't pull. Tug on the wire and see if the guide catheter is now advancing further into the vessel. Then you know that it is trapped a little bit. Now, that guide catheter then can dissect the left main in this situation, or the proximal right coronary artery if it dives back in. So we unhook the guide catheter and leave it in the aorta, and then start pulling the trapped wire. And by working with the guide catheter outside and pulling on the wire, you can get it out. Of course, if the wire does not come at all, then you have to put either a microcatheter on that wire behind the stent, or use a very small balloon behind the stent and then pull it out, and then of course post-deploy the stent. But you should never have a trapped wire, and you should not break a wire. It's very bad form to have a broken trapped wire back in a case like that.
Just because I have quite a good experience with broken wires behind the stent, to be honest. On the first run, I can say that maybe more than 20. And nothing happens with the broken wire. Even in the Handbook of Advanced Interventional Cardiology, where I wrote the chapter for the wires, I even placed one of these cases. It was 10 years ago. And what I can say that the first, if the operator is an experienced, the first reaction is just to pull strongly, which leads to two things. The first is the deep intubation of the guiding catheter and the longitudinal compression of the stent. And this causes even third problem, dissection, proximal dissection of the vessel, longitudinal compression, and breaking if you are very aggressive, you can even break or even you can cut the vessel, even with this, because I saw one such a case with the cutting the vessel during the withdrawal. And probably because the guys are looking at me and they have also such experience, because with Alexander we work at a couple of years, and we have quite a good experience with such situations and how to resolve them. And but anyway, the first thing is do not panic. And the second thing is just try with a small balloon to withdraw your wire.
You should protect the wire if you pull it, because it is the same as you work retrogradely. You should have a microcatheter, otherwise you can slice the heart.
But first,
but
small
especially in
balloon
this
is not to
situation,
cross the microcatheter.
I think the strategy, our strategy should be to avoid standing the left main. And to do this, we should have a clear picture of what is the thrombus burden and where is the culprit lesion. And I do agree that because there is a big thrombus burden, but this thrombus burden, I think, is distally. And in my view, just restoring the flow, which is the purpose of the primary angiography, primary angioplasty, probably is enough compared with stenting the left main, which can have a very, let's say, impact on the patients for the future. And that's why I agree, balloon, see the thrombus, try to aspirate, and after that, do the best with balloon angioplasty or stenting osteo to the left main, to the circ, in order to not to engage, especially in acute setting, the left main procedure. If not, of course, you can go, because I fully agree that thromboaspiration is very useful in some cases, and probably this is one of the cases, because you can get relief from the thrombus and can get rid of the treatment of the left main. And another comment, if you have this patient, clear elevation, I mean ST elevation, low pressure, it should go directly into the cath lab. I mean, echo, this is not necessary. Of course, if it's not postponing the procedure.
Thank you, Dr. Cvetkova. Excellent case with excellent discussion. Next presentation, weekend trifurcation, Dr. Ranchev from Alexandrovska University Hospital, Sofia.
Hello, my name is Sebastian Ranchev, and I work at Alexandrovska University Hospital, and it's an honor for me to present my case here today. And without any further delay, we have a 69-year-old male patient who presented to our emergency department in the early hours of a Sunday morning because he had a new onset angina, which started around 4 a.m. the same morning and persisted for about half an hour. He had history of badly controlled hypertension, and after a cardiology consult, he was admitted to the cardiology ward for further assessment. His physical examination was unremarkable, except for the high values of blood pressure and a sinus tachycardia. On cardiac auscultation, he had no murmurs, and he didn't have signs of peripheral or central congestion. His ECG was consistent with sinus tachycardia, discrete diffuse ST segment depression, some ST elevation in AVR, and some ST elevation in V1 and V2, but less than 2 millimeters in amplitude. From the echo, he had preserved left ventricular ejection fraction, mild to moderate mitral regurgitation, and wall motion abnormalities consistent with an issue with his LAD. His initial troponin was negative, and 1 hour later, it was still negative. And from the other blood results, he had definitely dyslipidemia and probably undiagnosed and untreated diabetes. His complete blood count was unremarkable too. And we assessed his coronary risk, and it was intermediate risk. And despite he was started on medications, his blood pressure was lowered. He had a couple of recurrences of his chest pain during the initial hours of his hospital stay. So after a discussion, the cath lab team was alerted, and we did a coronary angiogram the same day. We used the Judkins Wright diagnostic catheter to engage the right coronary artery. And there's some mild to moderate disease in the distal mid-segment. And there's a very small air embolus which was injected with the first injection, but it remained completely asymptomatic, and it was definitely not the biggest issue with this procedure. We used an extra backup 6 French guiding catheter to 3.5 to engage the left main. And we can see he has a large circumflex, which is represented by a very large marginal branch, which subdivides into 2 branches distally. And in the cranial projections, they overlap the LAD. And from the right caudal projection, we can more easily see that there's a problem with the proximal LAD, and it is best appreciated in the spider view. We can see that there's a proximal trifurcation, and there's a lesion, a subtotal occlusion of the proximal LAD, and significant first diagonal branch. We used the same guiding catheter, and the initial plan was to advance a wire into the LAD, but the wire instead easily went into the first diagonal branch, so we left it there. And unfortunately, the 3.5 EBU provided very poor support, and it disengaged the left main just by wire manipulation. So we decided to exchange it for a 4 EBU4, which provided much better support. And the first workhorse wire we used to run through again went very easily into the diagonal branch, so again we left it there. And we tried to wire it into the LAD with different wires, but it still proved difficult. At some point our patient started experiencing chest pain again, so we decided to perform a control puff. And we saw that the LAD had become completely occluded acutely, and the blood flow into the LAD was compromised. We tried from multiple projections with multiple wires to get a wire into the LAD, but it still proved hard. The wires either went into the first septal branch or into the first diagonal branch. And eventually, after a lot of contrast and fluoroscopic time, we actually managed to get the run-through wire into the distal LAD. And at this point, we performed the kissing balloon dilation into the LAD and the first diagonal branch. There was some plaque shift into the LAD. And at this point, we were very eager to get a stent into the LAD. And a 3.5 stent was advanced from the LAD to the from the LM left main to the LAD, and one was expanded. And from the caudal view, we can appreciate that the circumflex did not become affected, and there's also some spasm at the there's some spasm at the distal end of the stent, which was completely relieved by the time we removed our wires. And the diagonal and septal branches are also both preserved. And we also have this in spider. So at this point, we decided to finish the procedure. And that's pretty much the case. And I would like to thank you for your attention.
Okay. If
you were lucky. Because what I observe at the end of the procedure is, I think the stent is proximally oversized, but the problem is not this one. The distally very oversized. And in this situation, you can close all the branches. And the spasm you had distally was probably aggression of this of the wall of the LED. So normally, when we do a crossover stenting, which is you know, it's a trifurcation, but it's a simple lesion. In fact, you put the 3 wires, you put a bit difficult for LED. So normally we go to the most difficult first, but sometimes we don't know which one will be the difficult. So having 3 wires, first you don't do a preparation with kissing. Because if you have a dissection, then you will make the treatment of this bifurcation much more complex. So after that, you choose the stent from the distal diameter of the LED. So much smaller than what, I mean, half the diameter of the one you implanted, you deploy. In 1 time, 2 times, 3 times, you deflate. After that, you come with the balloon adequate for the proximal. Maybe as big as the one you used. And after that, you may stop the procedure as you did, because the diagonal is still here, with a moderate lesion, and the septal has no lesion. So this is the way to perform safely this kind of bifurcation. If the diagonal deteriorated with a long lesion, you exchange your wires. It's still patent because you have not oversized your stent. So you exchange your wires, you pull the LED wire, go to the diagonal, pull the diagonal, put it in the LED. Then you do a delicate kissing. And after that, it's finished. It was massively oversized. So this is something you have to choose the diameter from the distal diameter. This is major point for crossover stenting. This is the beginning of the strategy as defined as provisional stenting. If you don't do that, this is not provisional. You know, double preparation with kissing, you will have to do double stenting. You are, a lot of problems are coming. You are lucky, so this is a good result.
And probably the other point for discussion is that I didn't see proximal optimization. I think when you use such a I'm not sure that the left main is 3.5. Definitely, probably the patient required optimization in a stage procedure with imaging. Otherwise, we can have big troubles with flare stent everywhere in left main.
I just I will tell you in details what I think afterwards. First one. This is because he was my fellow, and yes. Yes, and we are only friends, and I will tell you in detail later on what I think. But the most important is what Dr. Stoyanov also said, that this stent, you have 3.5 LAD, and maybe at least 3.0 circumflex, which means 6.5 summary diameter, and 70% of 6.5 is around 4.5. And that means that for the left main, this stent should be optimized with at least 4.5 diameter balloon. This is very important for the prognosis of the patient. Maybe somewhere you can, yes, you choose the stent just to cover the left main, the proximal LAD, and hoping nothing to happen in the distal mid LAD. But one size do not fit all.
Just also a technical trick. If you have problems going, you can put the wire into the diagonal first, no problem. Take a dual lumen micro, it's like, and then you get the wire into the LED in 5 seconds. Yeah. It's very, very easy, but otherwise you can struggle and struggle and struggle, and 1 wire, 2 wires, 3 wires, and that gives you a little support. You protect the diagonal basically, and you get in the LED very fast.
Yes, double lumen with reverse wiring. There are a lot of techniques. They were lucky. If summarize everything with this sentence. But the winners are not judged. Okay, thank you.
Thank you.
Okay, the next is Dr. Borisov from Sliven. Is it here?
Hello, dear colleagues. I'm Dr. Borisov from Hadži Dimitar Hospital in Sliven. Thank you for the opportunity to present you this case of complex PCI in high-risk STEMI patient, or should it be complex at all. I present you 68-years-old male with chest pain, palpitations, nausea, and dizziness, started about an hour prior admission. Risk factors: type 2 diabetes, hypertension, dyslipidemia. He presents in KILIP class 4 with low blood pressure and diaphoresis. ECG shows sinus rhythm with ST segment elevation in first standard lead, AVL, and V4 to V6. Transthoracic echo reveals anterolateral hypokinesia with ejection fraction of 46% and mild mitral regurgitation. Blood test shows high levels of troponin, cholesterol, LDL with relatively normal kidney function. We started catecholamine infusions, and patient was transferred for urgent coronary angiogram. This is the right coronary artery. You see high-grade stenosis in proximal segment with opened septal collaterals to LAD. And this is the left coronary, subtotal occlusion of LAD and total occlusion of early diagonal branch. We did not lose any time, started PCI, standard radial approach, 6-French Judkins left 3.5 guide, run-through guide wires, and fine cross microcatheter for safe crossing the LAD lesion. After passing through the lesions, 2B3A inhibitor infusion was started. We did balloon predilation, and it implanted 2.5 by 23 stent in diagonal branch. Okay, so far so good. How should I proceed? Should I stent left main to LAD? If I do that, I risk compromising intermediate branch, supplying large zone of viable myocardium. Risk of life-threatening arrhythmias during distal left main treatment, because only PD is coming from the RCA, which has a high-grade stenosis proximally. And there's a risk of stent fracture because of the big differences between left main and LAD diameters. If I go osteo, I have only one bifurcation to treat, no need of occluding left main and causing global ischemia. It can be done comfortably through a 6-French guide, and if something goes wrong, the option of bailout left main standing will still be available. I decided to go osteo, 275 by 33 mm stent in LAD, crossing over first diagonal. After post-dilation and pod-kiss pot, there was a flow-limiting dissection of the diagonal ostium, which was covered with second stent using tap technique, followed again by kissing and final pot. This is the final result. Restoration of blood flow in LAD and diagonal led to an improvement in hemodynamics. Catecholamine infusion were reduced and finally stopped. Patient was stable without chest pain, so I decided to delay the RCA and PCI. Patient was discharged without complaints. 3 days later, stable hemodynamics, medical therapy, ticagrelor, aspirin, rosuvastatin, ezetimibe, zofenopril, amlodipine, trimetazidine. A month later, he was admitted for the planned PCI of RCA with class 3 stable angina, good control of heart rate and blood pressure, good left ventricle ejection fraction, and significantly lowered LDL. The result of previous PCI of LCA was preserved, and we did the PCI of RCA as promised. In ACS patients, especially in high Killip grade, restoring the blood flow as soon as possible is very important. Bifurcation's anatomy is frequently unknown. The tap stenting is feasible and safe technique for bailout stenting in provisional approach in patients with ACS. The main advantages of the method are the compatibility with 6-French guiding catheter, the complete coverage of side branch ostium, and the facilitation of kissing balloon inflation. And most of all, we must never forget there's a living person on the table, so always try to keep it safe. Thank you.
Well, congratulations. Thank you for this case. It's a clear demonstration. Nikki?
Excellent result. Congratulations. I have one technical question because I saw that you perform a tip injection through the microcatheter in such as settings. Do you routinely use this technique, tip injection, to confirm the position of the wire in the microcatheter?
Well, the wire was going into dissection, and that's why I used microcatheter to cross it and inject it just to check if I'm in the true lumen.
Yeah.
Okay. No, if not, do not have comments, this is a good sign. Definitely. That means that you made everything properly.
No, I mean, this comment, a technical point, when you have some infarction, you don't know the distal vessel. Even you go, you inflate balloons, and what we do is a double woman microcatheter or a fine cross, and you go distally and start to explore the vessel. And that gives you an idea where to put the stent much more easier.
By the way, I in those cases use export catheter. It's a larger lumen, but if it passes, and I use the export not for thrombus aspiration, but for the injection, slowly, delicately, slowly. It's the most important word. And this is, yes, and if, yes, just, but if you're in false lumen, the export will not cross, definitely. With the microcatheter, it is much larger chance to go into the distal part and to make a much more purazie.
But sometimes when you do not have export catheter
Okay.
and a large thrombus burden, the visualization through the microcatheter, it is not bad to see the size of the diameter if you cannot perform this thrombus aspiration. And we can put the stent directly.
Why don't you go both on the second row just to be seen from? Yes, because you cannot see you. Okay, so thank you. A really good case. Congratulations. And now is Sashko Nikolov from Macedonia. This is a very, very interesting case because we saw the cases previously, and this is really interesting, I think, that for all the audience.
Thank you for having us again here. Since 2015, we are almost every year, except the COVID part, where we skip it. And it's a pleasure being here, listening all the cases, all the lectures from these masters of the interventional cardiology. Today I will discuss about SCAT. My colleague from Serbia already introduced us very good with a good presentation. This is a SCAT patient starting from optimized medical therapy to reverse culotte. So it's a patient, female, 44 years old. She was referred to our ward because of the chest pain 2 days ago. We took a lab and the troponin was elevated and the ECG change was affected actually during the patient was administered into the ward. So we do the ultrasound regularly. There was a 50% ejection fraction with the anterior apical hypokinesia with the normal duplex of the carotid walls. The troponin was high, so we went directly to the cath lab. As you can see, there is a patent RCA, and this is the spider view of the left coronary system. You can appreciate some haziness in the left main. And this is the cranial view. You can see some stenotic, or as you can see, limited lumen of the LED. We put nitroglycerin intercoronary so we can see if it's going to be better flow, but the flow was the same. So we were quite sure that this is a patient with a spontaneous coronary artery dissection. So we put her in the intensive care unit. We put the therapy, and we put adrenaline because of the anterior wall hypokinesia. And after 6 days, the troponin went down from 2,000 to 800. And it was 28th or 29th of December. The patient was emotionally, she wanted to go home for the New Year's Eve. And I was emotional to the patient and said, it's okay, let her go home for the New Year's. And in that time, I made the first mistake. I decided to go for a core diagnostic. So we did the diagnostic, so I will be sure that because I was not, during the New Year's part, I was not in my hospital, I was out of the country. And we see that we have a quite good vessels in the LAD system and the diagonal system. And we say, let's go, let's do another ultrasound, much better ejection fraction, and we let her go home. After 3 days, the patient came again, but now with a sharp chest pain, with an ECG elevation, and we went to the cath lab, and it was, we do the ultrasound, and we went to the cath lab where we saw completely disaster different picture. We put the wire directly, went to the diagonal branch, we make a predilatation, and this was the result with a dissection starting from the left main to the diagonal with no LAD at this point. The patient was completely unstable at this point, so we continue with providing one branch so we can stabilize the patient. We managed to put a drug-eluted stent starting from left main to the diagonal, 3.5 by 48 on 14 atmosphere, and after it we pull back on the 16 atmosphere, and this was the result. This was the result of the left main diagonal. After it, we did a POT, and with 3.75 by 12 non-compliant balloon, and make the rewire to the LAD, use the microcatheter to see if we are in the right lumen. We saw that we are in the right lumen. We start with the predilatation of the LAD, and, sorry. So this was the result after the predilatation. So we decided to go for the reverse culotte, actually improvised reverse culotte. We put the stent from LAD mid-prox to the LAD distal. This was the result after the stenting. We do the pot, the kiss, the final pot, and this was the result. We can appreciate after the stent of the distal stent of the diagonal, there was a flap that was still presented there, and I was quite afraid to leave it like that. Otherwise, the flow was good, but I was afraid to have another lateral infarction, so we decided to put a stent there too. We stented, and this was the final result of the patient. The DCG elevation went down. The ultrasound after 5 days was much better. The troponin from 50,000 went down. And actually, what's the media presented, it's what media presents, what's the reality. This is the SCAT, and Dr. Mitov earlier that spoke about the situation about the SCAT, the types of SCAT, and the things, what are we going to do in the cath lab, either treat it or either leave it of optimal medical therapy. But it's very good to know when you make the mistakes. So we make 2 mistakes in this patient. First, we do the diagnostic too early. And the second mistake was that after the diagnostic, during the diagnostic, we gave 5,000 heparin to the patient. And we actually provoked the intramural hematoma of the vessel in 3 days to again open and make the occlusion of the artery. This is probably the reason of this.
And prasugrel.
Prasugrel, yeah. Yeah, that's the third mistake that we did it. And we had until 2020, all the 2023 year, 10 patients with SCAT, all was treated optical medical therapy, including this one, because we let her go home, and she came on the 1st of January in 24th, and actually all the other 9 patients were treated quite good. Now on our ward we have the first for 2024 SCAT patient, but she will be for 10 days in the ward and let her go home. Thank you for having us here.
Congratulations for this case, Deity. It works. No, it works. It's okay.
Congratulations, Sashko. It was really technically good. I think that you were very, very brave to put the stent in the diagonal before wiring LAD.
It was
probably it was very difficult to recross the struts to find the location of LAD without. How did you find the LAD?
No, afterwards there was a small sign of the LAD. It was shown the LAD after the stent, but at the beginning I didn't put on the presentation. The patient was quite hemodynamically unstable, with no pressure, with nothing, and this was.
So you have to make
some
some
I had to put some flow so I can stabilize the patient, and afterward.
That was you didn't want to lose the time.
After we put the stent in the diagonal left LAD diagonal, there was a shown of the LAD, but I didn't know if it was a dissection or it was I was going to the dissection or to the true lumen, and that was moment of truth. Actually, I did it like that. Is it good or right? At the end, it was good, but maybe I was lucky, maybe not. But at the moment after we stand the left LAD diagonal, left main LAD diagonal, the patient stabilized, and after it was a regular procedure.
Congratulations again.
Maybe it's not a bad solution to repeat angiography after month, 2 months, we have a resolving hematoma after this period, and you must be can to do balloon dilatation of stents after this period. Yeah.
It's a good clue.
IVUS is ideal, and yes, and POBA if it's necessary.
You saw a filling defect in the diagonal, correct?
Well,
Yes. You saw a linear filling defect. I'm not sure whether this is a flap of dissection intima that's protruding through the stent struts, or is this a piece of thrombus? So in situations like that, instead of putting another stent in this otherwise normal vessel, you could image the vessel.
Yeah, we are now
may not have it.
we are now in procedure to have OCT. Probably we'll have it this year, and it was a flap, classical flap.
Did you?
Yeah.
So you did it?
Yeah.
I think it's worthwhile. When you're not sure what's in the stent, it is worthwhile imaging it. Because then you'll give the appropriate treatment. The appropriate treatment for a flap is to put another stent in. If it was thrombus, it's not the appropriate treatment. So.
Congratulations first. Second, I'm surprised you did inverted culotte very well. So I'm surprised that I've not seen you in bifurcation club, so you have to correct that. And on the technical aspects, about the fact that you stented toward the diagonal branch, I think is good, providing you're absolutely certain that you are in the true lumen. If you are not certain that you have the true lumen, then access will be possibly impossible. So I agree that with before stenting towards the diagonal, I would have image.
Yeah.
You know, you may think that I'm against imaging, but not at all. This is a perfect situation to have to be absolutely sure that you are putting the stent in the lumen.
Yes, of course.
If you put the stent in a false lumen, then you close the access to the side branch, to the main branch in this case. And if you put a stent, you are sure to be in the true lumen proximally and distally in diagonal branch, you will increase your chance, of course, to go to the LAD. Not decrease.
2015, Professor Lovaart, we have the culotte presented here in Tucud. And you will discuss it.
One, let's say, tip in those situations, what I do. When the wire is distally and I don't see, I take 2.5 or 3.0 inflated balloon, previously inflated balloon, just to have a good wings, and I go up to the distal part of the vessel, just to go with the balloon all the time, to be sure that my balloon moves freely. And this is the most simple test you can do without doing anything, just because the balloon per se is like just like a Fogarty catheter, but just soft Fogarty, just to be sure that all the way you have good open vessel.
We're doing the same.
I know, just to be clear.
That's good to know that it's a good way.
Yeah. Okay, Sashko, thank you so much. And the last case?
Last case is from
Dr. Kernov.
Kernov.
Hello, my name is Dr. Penev. I'm from Pirogov Hospital. I will be glad to share a recent case from our clinic. It's about a young male, 45 years of age, who came with a new onset of chest pain about 30 minutes prior to his first medical contact. From his lab, he had a little bit elevated cardiac enzymes, a little bit elevated glucose, and a very elevated LDL cholesterol. Also, he had an ST elevation in his precordial leads. What he later told us that he actually knew about this elevated LDL cholesterol for about 10 years. and it actually reached levels of up to and above 10 millimoles per liter, and but it was left unaddressed. So we proceeded with the angiography, where you could see from the left coronary he had an occlusion of the proximal part of the LAD, with also significant osteostenosis of this marginal branch and another stenosis of the circ. He also had a lot of plaque in his right coronary artery, as you could see. So we proceeded by wiring the LAD, which actually provided some decent blood flow in the LAD. And this showed that the LAD had a very large disease segment, and also the patient actually had a double diagonal branches coming out of a single osteum, which also had a significant stenosis in this case. So we proceeded with our procedure. After some short thromboaspiration, we did direct stenting of the proximal part of the LAD with a 3.5 stent, a very saluting one. And we tried to relieve some of the stenosis of the diagonals, which naturally led to some dissection in the more cranial one. And at this point, we figured out that this would be enough for this procedure. We talked to our patient. We discussed the different options for further revascularization, and he was initially very reluctant to go with the surgical one. Nevertheless, we agreed that he should come for a checkup in a couple of weeks, which you might guess that he never did. So last week, he came out to our ER with our current angina, which he reported had for several hours previously, with some elevation in his troponin, now normal glucose levels, which he also, as you can see, had a significant reduction in his LDL cholesterol with 1.8, which actually didn't result from our therapy. He went on to a different cardiology specialist, and he received a PCSK9 inhibitor. Sadly, he didn't take his statins and ezetimibe because he reported having fevers and muscle pain when he does. He has persistent ST depression in his inferior leads. Luckily, his ejection fraction actually was pretty decent, and some minor hyperkinetic areas. So we proceeded with our angiography. The right coronary artery was basically the same as the 3 months ago. So the left coronary also actually had no signs of instant stenosis. As you could see, he actually has some minor aneurysm, which is covered by the previous stent, with persistent stenosis of the marginal branch and the circ, with somewhat slow flow in his LAD. He also had persistence of this dissection in this more cranial diagonal. So at this point, we again discussed with the patient. We had calculated his syntax score, which resulted in a value of 24, which basically gives us two options for further revascularization. He again absolutely rejected the surgical option, and as you can guess by now, we proceeded with the PCI of the LAD, and we tried to preserve these very significant diagonals, which actually supply a big percentage of the myocardium. So we started with pre-dilation of the both diagonals with some 2 millimeter balloons. We wired all the three vessels of interest, and we initially relieved some of the stenosis and proceeded with stenting the more caudal diagonal with a 3 mm stent with overlapping to the more proximal stent from the previous procedure. This is the first result. Then we opened some struts to the other diagonal with the 1.5 and then 2 mm balloons, so we could advance the other 2 mm stent we implanted in the diagonal. We formed the new carina with NC balloons, 3 and 2.5 mm respectively. And this is the result, which was satisfactory. So we proceeded with stenting the large segment of the LAD which had diffuse disease. This 48 mm stent was not enough, as you could see, so we placed another 3 mm stent to 23, so we could cover the whole diseased segment. We followed that by opening some stretch to the diagonals with this casing, and did the final tracing with NC balloons in this trifurcation. Generally, of course, we followed it with final pot in the LAD, proximal part of the LAD, and this is our actual final result. We, of course, discharge our patient on beside the antiplatelet therapy. We gave him ezetimibe and started a low dose atorvastatin. He received rosuvastatin the previous time, so we started low dose atorvastatin with the option of escalating this therapy if he didn't receive any side effects from our treatment. And we are considering a further procedure about the CIRC lesions. So, thank you.
Thank you. Comments? Congratulations first.
Yeah, that was very creative.
Yes.
You don't have to dilate all three. You could do 2 and 2. Because if you look at it, that third diagonal is still pinched. You're never going to get a perfect.
It wasn't the perfect result about the second.
But yeah, you could put the 2 balloons and alternate it, and I think you'll get equally good result. Do you use a 7 French guide?
Yeah, 7 radius.
There is no way you can do it 6. Finally, that you have not an aneurysm, it's a pseudoaneurysm in the proximal LAD. Because and you don't know the natural history, so probably plaque rupture, plaque ulceration, stent, and now you have a pseudoaneurysm. I don't know how you would follow this person. The incidence of pseudoaneurysm rupture is very small. You see it. You used to see it with the thick strut stents in the past, especially Cypher. You don't see that as much nowadays.
But probably this patient should live lifelong on the double antiplatelet.
Yeah, so many stents. Yeah.
So, congratulations for the skillness. The name tracing was given by my associate Thierry Lefebvre in a paper. I remember that. So we were very proud a long time ago to be able to perform this kind of things, in 35 minutes. And with the tracing. This is a performance, and it is testifies of your skillness. Congratulations. So if you look in first, technically speaking, you have a place in this vessel where there is 3 overlapping stents. The one you put in the first time, then the second stent coming from the diagonal, and then another one in the distal LAD coming in the 2 previous ones. So you have 3 layers of stents. We know that this is not this is not useful. You have 3 stent delivering drugs. This is from a very old trial, a desert trial overlapping stent is a factor of stent thrombosis. So avoid that. Avoid that. And the other point we learned, you know, we did this travel, you know, with you. We were very proud to do that, I said. But when Dr. Koo told us that the concept of clinical relevance, he said that some branches with a stenosis, there is no advantage to treat because they have no influence on the future, was coming from a paper by Kushula-Kanti a long time ago, telling that you have, this is in European recommendation, you have to revascularize a vessel if it is representing more than 10% of myocardium. It's not easy, but today we can measure that with some software in CT scan. So the two diagonals could have been avoided completely. So a long stent, even a very long, from LAD to distal AD, with 2 wires in the diagonal. You choose the diameter from distal, you do the pot, and after that, except if one diagonal is occluded, or if the flow is decreased, or you have a new ST change, you don't do anything. So this is the beauty of provisional. Typically, you can do provisional because normally you don't have to treat these diagonals. You have to treat if necessary. So we changed our mind since the beginning of the 2000. What we were doing, what you did, we changed our mind and we apply for this. Even in this situation, we apply the provisional strategy.
Yes, thank you. Well, it was a concern that we would leave actually three layers of stent, which, as you say, is a risk. I agree, but as you could see, there actually all 3 vessels we used 3 millimeter stents, so these were pretty large diagonals, which we think were supplying a consider a very large amount of myocardium. And
your 3 stents, is this 3 times 80 micron, 3 times more?
Yes.
So
this
is probably double the scaffold. Remember the history of the scaffold.
Exactly.
Yeah.
To absorb.
Probably 3 layers of scaffold on some time.
Yeah.
2 new carina, disturbance of the flow. So I think it's most important thing is
this technique. You cannot remove what you have done. Using the provisional, you can add something which is necessary, not add if it's not necessary. Even with Xiaoyang Shen, the creator of DK Crush, so popular today, he changed his mind. Now he minimized the overlapping. Minimize. So no question of 3 layers. He minimized two, 3 struts. That's all. So we have to keep that in mind. This is impatient. I think probably you will live very well and no problem. But if you do that in a large study, you will have a percentage of problems. So I don't think this can be the best choice to perform this procedure. Is incredibly good for an operator, of course. But
yeah, there are different ways to go about it. I agree, definitely. More often than not, we go with the provisional strategy. But this case was interesting to us, which we decided that this will be, considering all the factors, it will be the best scenario for our patient. And we also don't close the door for further surgery. As you could see, there are places which you could place bypass grafts further down the line. If
we can see whether this lateral wall is suffering or it is only the apical part of the LAD. In my view, in this case, this is a young person who is quite ill, and we should do really minimally invasive. If the apical wall is suffering, that is probably the LAD, and you can do a measurement FFR or something of the kind, and there you can put even a Magmaris, which this patient is quite suitable for this one because the vessel is around 3.0 and even high, and you can put easily a Magmaris that will disappear in 6 months and will left the vessel for another treatment. And what I'm pretty sure we can do the LAD only spot where it's needed. Even if the bifurcation is not treated and is left done in this way, we can go for another stress test that will provide that we have additional a substantial amount of ischemic myocardium. And what is happening that we know from the ischemia trial, and probably it will be reflected in the guidelines, nowadays even 2 segments are not enough to justify the procedure of revascularization. And, but if there is, probably we can go after that on a second procedure and treat one of the diagonals, again trying to stay with balloon, drug-eluting balloon, or stent at least in one of them. That's what I think, and what probably I would do. It is not throughout that which is wrong and which is right, but my way of thinking in this direction.
Unfortunately, I think that with this type of geometry of bifurcation, with the very shallow angulations between branches, it is very, very difficult to achieve good result without stenting. The problem with 3 stents appears because of what we established as extension distance mismatch, which occurs with the maximum achievable extension perimeter of the stent and the elliptical distance from the lateral walls of the main vessel and side branches. And in this case, this is a very, very large distance, and it is just not possible to stretch your stent just to cover the whole lateral to lateral walls of the bifurcation. And this puts definite limitation of the technique, and this is why personally I have several similar cases, but I never put a 3rd stent just because I'm always afraid of these 3 layers of metal which are just undelatable. This could not, the final result, there is a clear osteum of the mid-diagonal. There was a pinching, and this pinching will be always there. You can make a tracing. You will see how the balloons during the tracing are opening, but when you deflate, one of the vessels always collapse, just because, and the construction of the bifurcation is with a figure of 8 of the elastic tissue, which always collapses. These are anatomical restrictions which there is no stent at the moment which can overcome this physical anatomical limitation of the bifurcation. And this is why after first making maybe 10 years ago during the live case in Warsaw on the Robert Gill, I made it live, and the audience was amazed. It's very good, very how to say, for self-esteem.
Promote.
Yes, but a few days ago, afterwards, one of the branches thrombosed. And this is very refreshing after that. And just after that case, I personally stopped to place more than two stents. That's enough. Trifurcation, 4 vessels sometimes it appears in the left main. We have such a patient, but I never, ever, no matter how, if the timid flow is 3, that's enough.
Yeah. I have a proposal. There is a good paper that wrote by Mila, I don't know her last name, from Novi Sad. She worked with Burzota and published a paper about treating traffications. Yes.
Kovacevic.
I have a proposal for you. You will do the control angio 9 months after this. And we call you to come next year and present us.
Yes.
Maybe one of the title of your presentation will be the less is more.
Okay, so this is a very good proposal from DATI. Just next year to make a follow-up of all the cases. That will be a good, we will recruit additional audience, that all the presenters should be here next year just to present the follow-up of this year cases. Thank you so much, and I thank you for the attendance.